tools based on medical guidelines, and language processing, and then obviously computer vision and can help in endoscopic features. There's where pattern recognition for images is very useful would be in gastroenterology, radiology, pathology, and dermatology. So in decision making, what are some of the challenges? You have multiple inputs. You have patient history, you have electronic medical records that may span decades. The medical record may also span geography from different institutions. It can also be different formats from a hospital system to a lab, office, clinic. There's lab and image data, wearable data. Many people have like an Apple Watch, which can have a rhythm to tell you about a heart arrhythmia. We can even do wearable data where someone swallows a capsule to take a video of the small intestine, and that can be reported back as well as people who with diabetes who have glucose monitoring. And then obviously we can integrate genetics, genomics for predictive medicine. So AI models can develop a recommendation and plan by basically taking all that information, leveraging existing medical guidelines, and give you an idea. It'll be a responsibility of the physician to then put that into context and see which of that you'd want to use or not use, and it results with sort of shared decision making. And the idea here is that by continuing this loop, the system should get improved. Who taught man by the pen taught man what he knew not. And that's from chapter 11. So medicine is moving to this idea of 4 Ps, so where it'll become more personalized by taking all these inputs that we talked about, predictive by using genetic risks, family history, preventative because maybe we can then, if we know what you're at risk for, we can then prevent it, and then with all that information and data, maybe the patient will be more engaged. And so this is kind of a idea of how AI can be very transformative. You know, initially the big impact was like penicillin, and you can see how life expectancy has changed on this slide with the advent of better infectious practices, antibiotics, our focus on cardiovascular diseases with medicines to control blood pressure and cholesterol, as well as therapeutic procedures for the heart. And now the idea is with all this data, can it have an impact on health with both genomics, meaning predictive medicine, and then having people participate and be more personalized and engaged. So real world applications, and I'm going to focus on gastroenterology because that's what I do. And so I'm going to skip ahead here. So how can AI be efficient? And this is more of a general slide for anyone who practices. So ambient AI. So I can sit here and I could be a clinic patient of Dr. Salman here as my stomach is hurting, I probably need my gallbladder out, I'm a little overweight, and while we're having this conversation, the AI can take that and generate a note. And the AI is now smart enough that if we have a side conversation about our favorite sports team, it would not include that, and then create a note that's a template for review. And so in the time where he's speaking, instead of currently in clinics, we ask the patient a question, we're looking at the screen, typing away, almost no eye contact with the patient. Now, it goes back to the old medicine where you're sitting there talking to the patient, they feel like you're engaging with them. To me, that's a value proposition. In endoscopy, this could also be procedural, and we'll talk about how it can help us identify lesions, and this can be for any field. Even in surgery, can maybe say, hey, this is where your margin is, you should cut here. There's a vessel there. I think of it like a GPS or a co-pilot. And administrative tasks, which is probably the biggest challenge and cause of burnout for most physicians, messaging, results, and scheduling. So ambient technologies such as transcription, I talked a little bit about how that would work. So there are already products like Microsoft Dragon that we use in our suite when we just transitioned to Suki, but there's also Abridge and Oracle. And the idea here is you can have your phone and you'll be talking to the patient, the phone is recording or listening, and it will create the note, transcribe it in the format that you would like. Data has shown that documentation time has gone down by 20%, and after-hour work has decreased by 30%. Let me explain what after-hour work is. So let's say I have 10 procedures. For me to write a ERCP or advanced endoscopy note takes 10 minutes per note. So if I did 10 procedures, that's 100 minutes, so almost 2 hours, that I have to do at the end of my day or in between. So the idea of getting that done will be very useful. before you see the patient in clinic, we would often review the notes the day before or that morning. Now this could all be done by AI and give you kind of a synopsis of, hey, this patient is coming in, this is what we should highlight. Or if based on our last visit, did the patient make this dietary change? And ask this question. And it can also leverage and bring outside imaging, studies, or surgeries that were done. And endoscopy reports, so the idea now is that while I'm doing an endoscopy, the scope itself will have a listening device. And while I'm scoping, and I'll call out, hey, we're at the cecum now, there's a polyp there, we're going to resect it with a 10 millimeter snare. That can all go directly into the note. We talked a little bit about administrative tasks. So one of the largest healthcare EMRs is Epic, and they have a partnership with OpenAI to create AI-generated patient reports to respond to healthcare messages or report results. So for example, if somebody's blood value is, hemoglobin is low, it can then say, hey, it's low, and then we're going to order this. I don't remember the next slide, sorry. And then patient questions. So there's actually so Open Evidence is another AI platform, and the idea here is that it has a HIPAA-compliant learning machine language, and the idea, it's been trained on medical literature. So could that product be used to answer the question? So patient writes the question, and the AI responds it, and the physician actually never looks at it. Are we okay with that? Are we comfortable? Do we trust the AI? So these are starting to bring up some questions. Could we go to the next slide? Sorry, I'm not able to move it now. So in GI specifically, there's CAD-E, so computer-aided detection for endoscopy, and then there's also computer-aided diagnosis for lesion detection. So it has options for value in both colonoscopy, and let's play this video. Let's see if I can click it. You'll have to click it, yeah. So here, they're doing a colonoscopy. The prep is pretty good. You can see the wall, which is pink. You may have to, yeah, play again. And so the AI is on, so it's going to have a green box when it sees a polyp. And that's the catheter, and there it is at the bottom. Now, could you see that without the AI? Probably. But over here on the left, maybe there's something that's hard to see on the fold, and it's trying to tell us there's something there on the right. And we're going to look at it a little bit better. And so there you can see the polyp. Now, there's enhanced imaging that could be done on some of these polyps to say, hey, is that actually a benign polyp or a real polyp? See, that looks hyperplastic to me because of the regular crypt pattern. But, you know, again, that is something that can be added. If you saw the slide before, the box even measured it for us and gave us size, because a lot of our guidelines are based on size. Why is that important? Well, we miss polyps, so for each 1% increased detection rate, you drop colon cancer risk by 3%. But the early data on this is mixed. So a large study of about 4,000 patients from Mayo Clinic found that this was helpful in increasing adenoma detection rate, which is our benchmark for how we measure our colonoscopy value. But a German study of 1,600 patients found that it was not helpful. So my personal opinion is that it's mixed, still learning. I find it best when I identify a polyp, and while I'm getting my tool to remove it, I miss it. It's nice to find it when I've lost it. So that saves me time. So we'll go to the next slide. These are just some of the FDA-cleared device. The one we used was the top one, GI Genius, but you can see there's a lot of work in this area from investors and companies. This is work from our lab where we looked at bowel prep. So can AI help people in learning how to have an excellent bowel prep? And the bowel prep is really important because if you have a better bowel prep, you will have better outcomes. And if it's not adequate, you have to repeat the colonoscopy, and there's an increased cost there. So really quickly, as I'm coming near the end here, so pancreatic cysts play a challenge to us because 10% of all people have cysts, but only 10% of those cysts could become cancer. So what do we do now? Everyone who has a cyst gets an MRI every 6 months or a year, and anytime a doctor tells them, hey, you have something in your pancreas, they get nervous because we know outcomes on pancreas cancer are not that great. So this is an opportunity to try to reduce unnecessary surgeries if we can identify based on imaging and patient genomics, which are important. So here's an AI. I don't know if this video will play. Click it. Oh, sorry. Thank you for playing it for me. So here's a lesion. Now, you can see that without the AI, so I'm not sure how it helps you there. Maybe it'd help us in identifying vessel involvement. Maybe it can create a 3D margin, so we may better be able to use a 3D framework to see what the stage is. Maybe it can tell us, based on imaging, morphology, what biology it is, so that maybe we can do therapeutics at the time of diagnosis. So this is a adenocarcinoma based on their regular cells. So coming to our summary here, so what are some of the advantages of AI? Improved diagnostic accuracy. Obviously, the machine can do well with reviewing in terms of inter-operator variability. It'll provide a more consistent result. Earlier disease detection, so that's an idea, and reduced, obviously, variability between different people. Opportunity to provide precision medicine and individualized therapy, and provide efficiency to us to decrease our burden. Challenges, there's going to be some bias. It depends on how that algorithm is designed, and if the algorithm itself is not created accurately, you may not get the right data. I'll give you an example. The normal guidelines for liver enzymes was based on the VA data. So the VA patients in the 40s to the 70s were predominantly what? Men and Caucasian. So we found that that value is actually not normal, is not the right value, and it's much lower because most of those men had what? Fatty liver. There's questions about who owns the data. To make these AI models work well, that data has to be used. But do you have to get consent from the patient to use that data? Should they be paid as a consultant? So these are kind of things that you have to think about. So ethics, medical legal aspects, who consents. And then you may trust the model, and we call it model hallucination. And so have false confidence, so you may have a false negative or positive. And then could this de-skill us? If you're doing a colonoscopy and you rely on the AI to tell you where the polyp, what is a polyp, then maybe you'll forget. So that's why when we're training our fellows, we try not to use this in the first 6 months. This is just a schematic of what we've just talked about. So my take-home points, AI has aspirations to be transformational in care and efficiency, but concerns remain on bias and the ethics of it, and will it be equitable for all? So the future is going to be ambient AI for documentation, which you already are going to have. Real-time procedural co-pilots, which you've seen some examples of, can be predictive in inpatient monitoring to predict who will be discharged so we can work with patient flow. Can it be multimodal? But we'll have to collaborate. These are my summary points. So it's already here. It has great value. And Allah has not sent down any disease, but He has also sent down a cure for it, as a hadith. So, thank you.
Thank you very much, Dr. Ahmed. So what we'll do is we'll just take maybe 5 minutes for questions. We'll go back and forth. We'll do it all at the end. Okay, I guess okay. Sister Farhana, is your speaker ready? We'll go with you.
Yes, they are ready, but the questions will go in the end, or you guys are going to do the questions first?
I think what I'm hearing we're going to do a panel at the end, maybe have all of the speakers come up, and then we can go back and forth, because I think there'll be a lot of common themes. So if you're okay with that, we can just proceed with the next speaker.
Okay. Assalamu alaikum. I would like to introduce my two speakers, Dr. Fazeeah Agoro and Zainab Agoro. Dr. Fazeeah Agoro earned her bachelor's degree in kinesiology from Texas Tech University and her Doctor of Physical Therapy degree from University of St. Augustine for Health Sciences. She currently serves as a physical therapist as Encompass Health. A Houston native, Dr. Agoro has a strong athletic background, particularly in volleyball, which helped inspire her passion for movement, health, and performance. She is deeply committed to serving her community and empowering individuals to achieve their highest level of physical function and well-being. Through her work, Dr. Agoro strives to help people move better, live stronger, and discover the incredible potential for their bodies. Zainab Agoro earned her Bachelor's of Science in Nursing from Prairie View A&M University and her Master's of Science in Nursing. To becoming a nurse midwife, she spent 5 years working as a labor and delivery nurse, gaining extensive experience supporting families through pregnancy, birth, and postpartum care. Her clinical experience spans a wide range of birth settings, including home births, birth centers, and hospital-based care, allowing her to serve diverse patient population with confidence and compassion. Outside of her professional life, Zainab enjoys expressing her creativity through do-it-yourself projects, painting, crocheting, and creating intricate henna designs. Would you like to?
Assalamu alaikum. Jazakallah for the introduction. Today, our slides will be about reshaping AI and how it is applied in our workplace. Next slide. Or do I have a clicker? Or they'll do it? Okay. Okay, next slide. Perfect. So this slide really is just reiterating what I do as a certified nurse midwife. I specialize in women's health across the span of a woman's life. I am able to provide gen care, reproductive, or contraception, and my personal favorite, labor, delivery, and postpartum care.
I'm Fazeeah, assalamu alaikum, and thank you for the introduction. I work in an inpatient rehab where we focus on, neurological deficits and patients who are post-orthopedic surgeries. Next slide, please. There it is.
Okay. So, thank you. I think I'm gonna go on the other side. Oh, okay. Perfect. So this, basically, this is a study that was done in 2026. It took about 3,560 hospitals and surveyed how AI is being used in those spaces. And basically, before now, in 2015 to 2020, AI wasn't yet available in hospitals. The adoption of AI was just talked about and wasn't necessarily planned or working on being planned on. And most clinicians didn't use AI at all. Fast forward to 2023 and 2026, approximately 31% of those hospitals are now actively using AI with their electronic health record systems. 24.7% are planning on adopting the use of AI within the next year, and 75 to 76% of healthcare professionals report the use of AI in practice, whether it be with documentation or patient reports, things like that. Next slide, please.
So in physical therapy specific, we use a lot of external devices to help contribute with AI and our plan of care for patient treatment times and sessions that most of the times people do at home, or sorry, they'll usually do in a clinic or in the hospital. But here in the bottom left corner, we'll see like a gait training device where they can accurately take the objective information of your like stance and swing phase of your walking to understand where we see the deficits and what we can improve on a little bit more accurately in order for us to focus on doing the actual hands-on care instead of taking as much time with measurements and looking and seeing what it takes. Because a lot of times that physical aspect of breaking it down and getting the measurements can just take some time. So having that help with AI is very helpful. We'll also see with some outpatient clinics, they'll use sensors that they can send to their patient homes that they will apply themselves with assistance through like a video platform that will give feedback for your positioning with your exercises and if you're doing them accurately, how to contribute and improve so that you don't have to take as much time away perspective, they'll where there will be like a kind of third-party AI video capture to understand ways to make a procedure more efficient, depending on what the workflow looks like. And I think that's pretty cool because sometimes, again, we get caught in the weeds of everybody's doing their own thing and it's go time. However, taking a step back and debriefing with something like this can tell us where we can be more efficient and what we can cut off or what we can move around to get better outcomes for our patients. Next slide, please.
So, all of these different softwares are used for, or how we use AI in the clinic. There's Therma Office, there's Ambient, like previously discussed in in the previous presentation. There's Epic, there's AI charting, MedCenter. All of these are helpful in increasing the efficiency with documentation and billing. With the use of this, I've seen multiple stats about how it decreases time, which also decreases the amount of time that we use on charting after work. And in addition to that, AI is also able to help generate patient education sheets and pamphlets. These things are really helpful for when women are diagnosed with preeclampsia, with gestational hypertension, with diabetes, with placenta previa, all of these complications that come with pregnancy. And so AI being able to generate this, we give it to the patient, they're able to take it home, they're able to kind of understand what their diagnosis is, come back to us with questions that we can answer and have face-to-face conversation about, versus going on Google and just seeing a wide range of information that is not necessarily applicable to them. And then that's kind of how we use it in the clinic. I will also say, like, using AI on the labor and delivery floor is helpful because it is able to take complex results and summarize them for easier review. So for example, like I said, let's say someone has preeclampsia, severe preeclampsia. We've given them meds, they've seen multiple physicians, we're going over the labor curve. All of these things can be computed into a single report sheet to where we can review easily, and the next provider who is assisting them can make informed decisions about what to do next. Next slide, please. Click one more time, please. Perfect. And so that brings us to, we've talked about how we use AI in our clinics, but we also wanted to talk about the limitations of AI in our everyday practice. Midwifery is very hands-on. We are with the patients, we are laboring with the patients, we are talking to them, advocating for them, educating them. And some of these things can't be done by AI. AI can tell you what to say, but not necessarily how to say it. And so one of the limitations include lack of true human connection, empathy, like I said, hands-on support, and emotional coaching. And then my next point would be AI's lack of ability to complete stat assessments. So for us, one of the assessments that we do are APGARs. I'm not sure if y'all are familiar with or not, but basically an APGAR is telling us how a baby is transitioning between the first 5 minutes of life and first minute of life and the first 5 minutes of life. With that becomes, if a baby is doing well, then there are no issues. They are transitioning well, we can leave them with mom and have no other intervention. But if a baby is not doing well, then they need resuscitation pretty quickly. And so there isn't really much time to try and input this data into a database to where they tell us what to do next. It is something that we have to be pretty proficient in order to continue to help and assure that our babies are safe.
Thank you. There's also, and I think in both professions, in physical therapy and in midwifery, there's a learning curve for our patients on whether we do these things that they get to take at home or they have to do them on-site where, these things take time to figure out. We are trying to get people with spinal cord injuries, people who don't have use of part of their limbs, or don't have the cognition to do these things, to also put on this extra task of like, okay, now we're going to use this overhead harness system to get you to walk again. And it's like that extra input that takes time for people to get used to. And there's also a lack of time with treatment sessions and provider and care, where we don't have as much time to give to ensure that the carryover is there. So it's something that we're working on, but the lack of time and the learning curve also present like big limitations. And as we've discussed throughout this whole day so far, there's a lack of some people who can't afford AI resources. And so hands-on care has to be continued, which is not a problem. It's just one of those things that we'll have to bridge for the future. Next slide, please.
We chose Surah Al-Ma'idah, chapter 5, verse 32. And whoever saves one life, it is as if he has saved mankind entirely.
We chose this because ultimately we want to use these tools to be better and to do better for our patients, for ourselves, making better outcomes in our world in general. So in order to do that, we have to start somewhere. And if starting somewhere helps somebody get along smoother, faster, or even just the educational part of trying to get us to a place where people have longer or better outcomes, longer life expectancies, then we're doing a service to each other and in the long run for all of mankind. So alhamdulillah, so far we're in the works of trying. Next slide, please.
So a few takeaways. One, stay curious. AI is constantly evolving and has growing potential to improve healthcare practice in general.
And it's not a perfect science. So, AI can make mistakes a lot sometimes in like on Google or Microsoft. You'll ask a question and they'll give you an answer possibly that they think that you want to hear. And sometimes you can circle all the way back and it's like now you're contradicting yourself, not the AI is contradicting itself a little bit. So it's important for us to do our due diligence and make sure you check your sources, ask for a source, even if you're not gonna go through a whole like PubMed or anything. And in establishments or in your workspace, having a committee to oversight the use of AI and how much is being used and if we're being responsible with it.
And then lastly, collaborate, don't depend. The best outcomes happen when healthcare professionals use AI as a source and a support tool, not necessarily a replacement of human judgment. Jazakallah, that's it.
Jazakallah. I give it back to you, Dr. Salman Ahmed.
Jazakallah. Adeel, Malik is here? Very good. Okay, the pleasure of introducing the last speaker. This is Brother Adeel Malik, titled Pixel to Prognosis, AI's Role in Modern Diagnostics and Imaging. Adeel Malik is the CEO and co-founder of ClearStep, an AI-driven patient navigation company that has raised over 12 million. Oh, took 10 million off. 12 million from leading venture capital firms. Under Adeel's leadership, ClearStep has partnered with major U.S. healthcare institutions, including Tufts Medicine, Mount Sinai, and Novant Health, impacting care access across 300-plus hospitals nationwide. Adeel has been recognized as one of Built in Chicago's 50 startups to watch and was named among Crane's Chicago 20 in their 20s in 2020.
Assalamu alaikum. Jazakallah. You can go to the next slide. And you go to the next. You can just go one more, actually. Thanks. So the AI diagnostics, obviously we just heard in this session, AI is being used all over the place in healthcare now. A lot of different use cases, but probably the one that is actually the most widely adopted and has penetrated care workflows the most is in diagnostics and imaging. And it's kind of to on the patient side less visible, but on the care delivery side is just now part of the normal practice. And some of the stats here, there are 950 AI medical devices that are FDA cleared. And in 2015, 10 years ago, there were 6. So this is a huge, huge growth in even the FDA's posturing over what they're okay with and how much they're leaning in to AI. And then 75% of those devices are for RN imaging specifically. This verse I thought was very interesting because, interestingly, if you look at the commentary, it is the main thrust is about the truth of Islam, and that the truth of Islam itself is kind of evident among the population. But it's interesting to kind of take this lens from an AI imaging perspective to think about how through these tools we are actually able to see signs within the human body more clearly and understand the truth of what's happening there more clearly as well. And like was the prior speaker just mentioned, this is now it's getting ramped even more aggressively. You can go to the next slide. More data to kind of make this point that there are across fields and across specialties, AI is already part of the way medicine is being practiced in mammography, better detection, ophthalmology, chest X-rays. What's really fascinating is how this use case with AI imaging is some of the best integrated into workflows, because it's already part of when images are first generated, there's already an AI report that kind of comes along with it. And so you can have a radiologist just jump right into that report. And obviously there's a lot of practicing clinicians in the room who see this or are recipients of these reports from radiologists, where the starting point was an AI-generated analysis of it. In cardiology and pathology, one point I thought I would make here too is that the FDA is actually really, really aggressively bullish on the use of AI in medicine. It's actually a little. I was almost surprised to understand the full extent of just how much the FDA is leaning in to AI. And one of the best examples of that is recently. So there's a government agency called ARPA under the NIH. It's kind of like DARPA for defense, where they try to fund like moonshot AI or moonshot ideas. And ARPA is currently actively, there's a solicitation. It's the most heavily funded government grant for AI, period. And it's like almost $500 million worth of money. And I actually just recently, I think they haven't announced it, but they've selected the finalists or the winners of those grants. Not just one company is getting split. Actually, clear several hundred. We made it to the final top 15 of that solicitation. We didn't, unfortunately, found out just a week or two ago. We didn't get it, but what they're trying to do is effectively create an AI cardiologist, and the FDA is leaning heavily into this, where it's in recognition that heart disease, #1 driver of cost in the country. Government really, and half of zip codes in America don't have a cardiologist, and the government really wants to push an AI that is capable of monitoring, diagnosing, titrating, actually adjusting care pathways for patients autonomously. And that's what this money is for. So we're going to see, and the FDA is partnered with ARPA on this. So this is an incredible, just how much the government is actually leaning in to AI is pretty incredible. You can go to the next slide. A couple other examples, I think. What am I at right now? I'm not okay. But there are a lot of examples. I put some here on missed AI proven to be able to catch cancer at better rates compared to just human radiologists versus those supplemented with AI. There's automated retinal screeners. This is a cool use case. Actually, VizAI, we partnered with VizAI on our application with ARPA, and they're one of the most implemented technologies that are working in the background here with radiology reports to generate initial kind of summaries of what's going on. But VizAI proven that it can detect strokes really accurately and upon initial detection, and so the time savings that they've been able to show is the difference between someone walking or not, and how quickly you can surface a potential stroke. You can go to the next slide as well. So one really important consideration here is, and what the ayah at the top kind of alludes to, is the importance of actually making sure we are acting with knowledge and with wisdom, and that we are not unintentionally being unjust in what we put forward in these kinds of technologies. And so bias and equity in the way that the models are trained, in the way that they work, is a really important factor, which frankly, I will say in the kind of commercial AI world, it's easy sometimes to overlook this point and feel like you have a data set that's representative and it's working, and then you apply it to a minority patient population, and it's not as effective. And there are very real examples of how this has manifested, and some of them are here. 2021 study, dermatology AI performed significantly worse on darker skin tones. But I do see that the governing bodies, the FDA again, is even more sensitive to this fact. And that was also part of this whole ARPA solicitation. That was, there were health systems themselves that were applying to get some of this ARPA funding to test this technology. One of the main considerations that they had was how diverse is the patient population and how representative is it of the broader society. But for anyone kind of building in the space, this becomes a non-negotiable kind of factor to demonstrate that AI is actually fair, just, being used robustly, and is not unintentionally biased, especially when it is more and more affecting the actual decisions that are being made for patients' care. You can go to the next slide. I wanted to give an example of how at ClearStep we're doing some interesting work in this space. This is kind of a branch point off of our core solution. So the ClearStep's main technology that we've built is kind of what I describe as an AI clinical reasoning engine, where we can understand patient conditions, symptoms, presentations, histories, to engage in dialogue with the patient and determine what the next step should be for their care. And we've kind of taken that core reasoning engine and adapted it in some interesting ways. So most of the examples that I just talked about are part of the existing workflow, an image that's already being generated. But what we've done is we have a use case that's being used by one of our health system partners, Ochsner Health in Louisiana, with some of their urgent cares, where when patients walk in, the front desk staff is actually using our technology as part of intake to do a more robust clinical intake with a non-clinical front desk staff. And so patient describes their symptoms, and we predict, even though we're geared towards triage, we're actually predicting the diagnostics that the patient is going to need. That was something over the last couple of years we've really expanded our corpus with, where we actually, we're detecting red flag. It's a big problem in urgent care is that patient comes in, they get roomed, 30, 40 minutes later, by the time the provider gets to see them, they realize this is an emergency case, and they have to call an ambulance and get the patient out. That happens daily at urgent cares, and it's a big liability concern and obviously clinical outcomes concern. So we're flagging right at the front desk whether this is an emergency or not, and then calling the provider to come validate this and triage the patient out. That's not happening in most of the cases, though. In 95+% of the cases, it's not an emergency. They belong, maybe belong in the urgent care, at least don't belong in the ER. And so it's maybe a little bit hard to see, but this is kind of this summary report that's generated, and at the top, I could only fit some of it. At the top, there's like an HPI that's already written up. Basically, the start to the clinical summary note is already written up. A differential is ranked. You can see it a little bit. The top 5 differential is ranked. But most significantly to the clinical workflow, we have this 2 tiers of predictions on AI, on orders. So this says MA, medical assistant, to order a urinalysis and a pregnancy test. And then there's a second tier of confidence, which is the provider to consider, this additional, gonorrhea test. But we have these confidence intervals, and what's actually happening today is the front desk staff, non-clinical staff, are putting in these orders based off of the confidence thresholds of ClearStep, so that by the time the provider walks into the room, the clinician, the PA, or the doc, they already have in Epic, in their EMR, a summary note, a differential that they consider, and the results of these tests that have already been placed. So instead of having to come in, do the assessment, place a test, they're kind of getting a greater level of efficiency. So this is an example of how AI diagnostic workflows are happening now before patients are even really entering the system. This isn't an image that is already ordered, but it's happening ahead of time. You can go to the next. A couple thoughts on where this is going. Most of the AI imaging models are not large language models. I think probably everyone's familiar with OpenAI and Anthropic and how large language models and that approach to AI model building is really what's taken off. But what's interesting is with imaging, that's not the case, because you need a lot more precision. You can't have hallucination risk. So most of these are different kinds of machine learning neural network models. But that probably will change over time too, where you have the foundation models. Foundation models effectively means the large language models. Will probably be able to handle this kind of imaging at a greater scale, or at a greater level of demonstrated accuracy, at least on par with the current FDA-approved models. And the benefit of that too is that the reason why there's 950 FDA-approved models is because they're so narrow and specific for an exact thing that they're trying to detect. But with a foundation model that's broad, you'll get value of saying you can have one model that's able to do a wide range of testing accurately. Reactive to predictive, the examples I've mentioned too are, there's already something suspected, right? That's why an image is being done. And so there's an analysis on that image. But how can we use much earlier detectors in the journey to be predictive about what may be happening? There's some of this that's already happening. Cardiovascular risk being predicted from a retinal photo is one example. And then a lot of the more cutting edge AI R&D use cases are happening within academic medical centers, research that's being generated. This, I think, we're already seeing. It has become way more. The last talk kind of touched on this too, just in the last couple of years, and we went from like single-digit AI adoption and workflows to like 70% of clinicians are using it, whether that's like open evidence or using an ambient scribe or whatever it may be. And then globally, this is kind of penetrating. And one point on this is I'll kind of end here. I think many know that there's active work with Fazeeah Hospital in Rabwa to turn it into a center of excellence or transform it and really elevate the standards of care that are happening there. Everything we're talking about here of how AI is being used in clinical medicine are things that we are contemplating and planning bringing there as well. And that's happening all over the world, particularly in underserved markets or regions where you don't have the same level of healthcare resources to be able to apply. So the impact you can make with efficiency, with scaling providers, is even greater. And I think that was it. Maybe there was one more slide. Yeah, I think it's also interesting to look at the word ICRA, read from an AI imaging perspective of how deeply we're able to read into the human body autonomously without even needing it. Jazakallah. I know there's maybe 10 minutes or so for panel questions.
Jazakallah, thank you. So I'd just like to invite the speakers if they're welcome to come up, and we'll take some questions. We'll just go back and forth, I think one on each side. Any questions for our speakers?
Assalamu alaikum. So you guys were talking about how AI, you use it as a method for diagnostics and so on forth. And I wanted to ask, how much would you trust, so the AI trust factor is something that's I want to question, because as AI becomes more as it becomes more advanced, the more opaque the systems become. And with an opaque system, you can't really see what's going on behind the scenes. So for an opaque system that's, let's say it has a good track record, how would you question its results, especially with the dilution of false information throughout the internet and such?
So this ties to the point that I was making on large language models versus these other more precision AI models. So the angle you're coming from is from the vantage point of a large language model, where you know that ChatGPT hallucinates because it's just trained on the internet effectively, and it can give you inappropriate information or incorrect information. But these use cases that I was talking about that are at least today involved in actual care delivery workflows, they're not using large language models. There's effectively zero hallucination risk with the way those models are built and designed. So I'd encourage you and anyone else that is uncertain about this, kind of the details of what we're talking about here, just do a little bit of research via ChatGPT or the likes to understand what is the risk profile and threshold of different kinds of approaches to building AI. There's large language models, or these transformer-based models. There's neural networks and different machine learning models, and they have different levels of kind of assurance or confidence built into them. So all these FDA-approved ones being used in actual radiology workflows, they're not large language models. You can understand what is happening to a reasonable degree.
Right. To answer the question, I'm going to pose a question to my co-panelists. On your little screen there to Ochsner Health, would you get sued? Would you take the legal responsibility of that, or no? Who would hold the legal liability?
So we do indemnify our customers. The company, we hold the risk in enabling this kind of technology for hospital systems. And frankly, that's just the way it's going to be. The hospital systems are not going to. Now, it doesn't prevent the hospital from getting sued, but what would happen is the hospital would then sue the technology company. That has not happened. And
I just mean that illustrative. So he'll make the tech, but I'm the face to the patient, right? So one thing to understand is, while the AI power and computing is there, it's not greater than the power that's between your ears. You have over 100,000 synaptic connections. That power is greater than any AI model can create. So it comes back to you. So while it'd be great that ClearStep would indemnify me, but I'm not indemnified from the patient, because when I shake a patient's hand, there's a bond between me and them. When I do a procedure for them, there's a consent, whether it's me doing an endoscopy or Dr. Salman Ahmed doing surgery. We see them, we go over the risks and benefits, and it's our job to make that interpretation. So you're only as good as your model. Let's say the model we made was wrong. So for example, we believe that colon cancer progresses from an adenoma that gets irregular to dysplastic to cancer, and that pathway is 15 years, which is why we do screening at 10 years. But why are we seeing kids in their 20s and 30s get colon cancer? Are we missing something? Is our model wrong? And if our model is wrong, that AI database was built on published literature that could be wrong. And as Adeel Saab wrote and we talked about earlier, a lot of guidelines and data was based on white Caucasian males, and that they were inaccurate. And so it is going to still be your responsibility to review the data and see if it makes sense, because it not always will. I'm not sure if you answered the question.
We can go to the ladies for another question, please.
Assalamu alaikum. I just want to defend my specialty. I'm a radiologist. My name is Dr. Ahmed, and I have been in this profession for greater than 25 years. And the last talk, I just want to say that AI is a technology. It's all about machine learning than anything else. And just like any other evolving technology, we are using this as a tool in our medicine every day. And as far as radiology is concerned, yes, we have been using this, for example, in aiding cancer detection in the breast very early on. And later on, it's heavily utilized. For example, every day we use it for detection of cancer in the lungs. And as a user, I know there's lots of false positives. So AI may be evolving and is evolving, and there are no guarantees. You have to really, you cannot replace a human mind behind all these, programs and machines and all these models. You still have to look at it, use your brain power. And I always think in my mind, people are now just not using their mind, just going and just looking into different models. Like, okay, what does the answer come up? Maybe they're reducing their own brain power by not using their own. So that's my concern, and the data and the thought that was presented today, especially of the last presentation, gives you a false sense, in my view, as if it is just taking over. No, it cannot take over, because I believe that God created humans as the best of his creation. How come a machine or the AI models will take over? Because that will be the wrong way of going, in my view. It does help us as a tool, and that's it, and that's how we should take it and use it, and not think that, this is the best way to do it. I mean, there are a lot of false positives. I just want to emphasize this, that radiology is still, I don't know how this population will deal with, for example, reading chest x-rays or certain tasks. But I tell you, every human body that we image, each individual as a different outside, as different inside. So it will be interesting to find out how would AI deal with that. It would be very, very interesting. So thank you for that.
I just want to give maybe the lady speakers a time to respond, and then I think Brother Malik does have a response as well.
Assalamu alaikum. I would say I agree with that statement, especially in our respective fields. To address the first question that was asked, and as well as your statement, I think it's really important to make sure that we utilize it as a tool, and that it can't replace like human interaction, human empathy, human connection. And in addition, going back to the basics of what we did before AI came, in regards to looking at the peer-reviewed articles, the databases, looking at the different statistics and trends that happen in order to really compute a well-informed plan of care for patients. And then lastly, I would also just say that it's a tool. It's a tool, so use it as such.
Jazakallah. I'll just give the mic back to one of our speakers, and then we'll conclude the session.
Jazakallah, Dr. Ahmed. I'm so glad you're here and listening, that there is a radiologist kind of in the room here. And by no means did I mean to suggest that radiology is going anywhere as a practice, as a practice by people. In fact, the data, people talk about this, like AI enthusiasts talk about how radiology is like going away as a specialty, but the data doesn't support that. To your point, there's a shortage of radiologists. The data shows so far that all these AI radiology tools have just helped scale radiologists, but there still is a shortage of radiologists in America and globally. That's not going to change, and there's some like almost false positives. So, for example, radiology specialty selections or matches have gone down over the last few years, but that is not to do with the actual market need for radiologists. There actually are still there's still a shortage. So actually that the reduced amount of medical students going into radiology is actually more out of speculation for the future of the field than it is for the actual realities on the ground that are happening. So it is interesting to see, like, to Dr. Tharek's point, we're in a phase where these are tools for people to use to help scale their work, not replace them.
I was going to add one more thing. I mean, tools like Malik Saab's product will add is getting the right protocol. So his tool can identify, hey, we're worried about a pancreatic mass. How many times do the radiologists get the wrong protocol done for their image? So they'll order a contrast-enhanced pancreatic protocol with the appropriate slices. The other thing is we have, even in this country, we have healthcare disparities where you have Nighthawk reading films or there's no radiologist in rural America. You know, one of the missions of this entire session and this program is how do we bring healthcare, how do we erase the disparities in healthcare? Well, this product can help us read or make it more efficient to read images throughout the entire world, from rural Ghana to Fazeeah Umar Hospital in Rabwa to, you know, Chicago. So there are some opportunities where it will be very helpful.
All right, so I'm going to give a round of applause for all the speakers. Thank you very much. All right, so this concludes the session. Just some quick announcements. Lunch begins now, inshallah, at 12 downstairs, followed by Jummah at 1:30. Around 2:30, we'll be putting up posters. And the next joint session of the International Association of Ahmadi Architects and Engineers will be at 3 p.m. Please enjoy the rest of the conference. Salman.
We have one more comment about the lunch.
Assalamualaikum. I just wanted to add about lunch for everyone. So in the back of your badges, there are meal tickets. So please just have those ready. And inshallah, lunch will be served.